Just had your first sip of coffee, even have time to sit down, but a trauma just came in. A 4-year-old patient who just sustained blunt trauma to the eye. In this video, I'm going to go through the high-yield ophthalmology diagnoses to keep in mind anytime you're seeing a pediatric patient who sustained blunt eye trauma. And stick around to the end because I'm going to go through how to approach a pediatric patient that has significant periorbital edema to the point where you can't even see the eye. If you're new to the channel, welcome. I'm Dr. Alana Jasper Trotter. I'm a board-certified ophthalmologist. I've taken my fair share of trauma call, so let's go ahead and get into this trauma case. A 4-year-old otherwise healthy female presents to the emergency department with their parent after sustaining a trauma to her right eye. Earlier that day, she was running around chasing the new family puppy and ran right into the side of a table. The trauma happened 6 hours ago. She was initially seen at a local urgent care who recommended that the patient go directly to an ED due to the worsening periorbital edema and eye pain. And as far as the parent knows, there was no direct trauma to the left side, and there was no loss of consciousness. Past medical history, including ocular history and surgical history, are unremarkable. You're told that the patient has right eye pain and that it's been weeping clear drainage since the trauma, but there's been no hemorrhage or mucopurulent discharge that the parent saw. You're not able to get much information from the patient who's covering her eye and crying, and she tells her parent she just wants to go home and see her puppy. So you don't know what the visual status is or whether there's double vision. Anytime that you're seeing an eye trauma, make the patient NPO as soon as possible just in case it needs to go to the OR. Your exam of the right eye is pretty limited because anytime you get close to the patient, she turns to her parent and starts to cry. But you notice significant periorbital edema and erythema on the right side, as well as a small linear, non-marginal laceration on her right upper eyelid laterally with dried blood. She turns back to you and you ask her if she can open up her right eye, and she tries to, but because of the significant swelling, you can't see the eye at all. One of your team members come in to help distract her while you examine the left eye, which is found to be overall unremarkable. So the left eye has been cleared, but what to do about the right eye? Let's go through some important diagnoses to rule out in a pediatric patient who sustained a blunt trauma to the eye. Number one, if my back was against the wall and there was only one diagnosis that I could rule out in a situation like this, it would be an open globe. That's not to say that the other diagnoses are not important, because they are. But in these acute trauma settings, it's very important to rule out an open globe because it is a true ophthalmology emergency that needs urgent surgical repair. And people can lose their vision or even their eye as a result of this trauma. So if there's one thing that you take away from this video, pediatric blunt eye trauma, rule out open globe. Number two, it's important to rule out an orbital fracture. When there is a fracture present, you want to make sure that there is no entrapment of an eye muscle, particularly the inferior rectus muscle, because oftentimes the floor of the orbit is fractured, and that's where the inferior rectus muscle is. Number three, retinal trauma, like a retinal tear, retinal detachment, or commotio retinae. Number four is traumatic hyphema. A hyphema is where there's blood in the front part of the eye, specifically the anterior chamber, so that space between the cornea and the iris. Number five, traumatic iritis. When there's blunt trauma to the eye, that can lead to inflammation, not only surrounding the eye, but inside the eye. When there's white blood cells floating around in the anterior chamber in particular, that can lead to light sensitivity, pain, discomfort, as well as a pupil abnormality. Number six, vitreous hemorrhage, and that's where there's bleeding inside the eye in the vitreous cavity. Number seven, an eyelid laceration, particularly a laceration that involves the eyelid margin or the nasolacrimal system, both of which warrant an ophthalmology consult for surgical repair. Number eight, in any trauma setting, it's important to rule out an intraorbital or intraocular foreign body. This is generally less likely in a non-penetrating injury, but good to keep in mind anytime you're seeing a trauma patient. Number nine, a dislocated lens. This is pretty rare, but like anything in trauma, anything is possible. And if a pediatric patient has a dislocated lens, if that is not picked up and the patient does not then see a pediatric ophthalmologist, that could affect their vision and put them at risk for amblyopia. 10, traumatic cataract. You can think of linking 9 and 10 together because they both involve trauma to the lens. 11, a corneal abrasion. And 12, a subconjunctival hemorrhage. Although this list has some length to it, I don't want you to get overwhelmed by it. Common things are common. The highlighted diagnoses are generally more common in these blunt traumas. Majority of these diagnoses can be ruled out in clinical exam with a cooperative patient and minimal swelling, but often that's not the case in trauma settings. How to approach the ophthalmology exam when the eye is swollen shut and there's no view of the eye? Remember to make the patient NPO. These are the kind of cases that may need to go to the OR, and it's better to err on the side of caution while working the patient up, just in case. The key in the acute setting is to rule out urgent ophthalmic traumas that may harm a patient's vision or require urgent treatment or surgery, like an open globe. But it can be difficult to do this if you have no view of the eye due to significant periorbital edema, and this is where imaging can be helpful. Like in other traumas, a CT is generally the initial type of imaging. It can help to provide an anatomical view and assess the status of the eye, the orbit, and surrounding structures like bone and soft tissue, as well as to rule out a foreign body. In general, the recommended imaging in an eye trauma is a CT orbits without contrast that has thin cuts. So getting imaging can help to rule in or rule out a diagnosis, but it's an adjunctive tool. The key is the eye exam. So in a situation where you have significant periorbital edema, there's no or very limited view of the eye, and especially in a pediatric case, consult ophthalmology. If the exam by ophthalmology is limited, then an exam under anesthesia may be warranted either in the ED or the OR. Doing an ultrasound of the eye is another diagnostic modality that can sometimes be helpful to assess the posterior segment and look for an intraocular foreign body, retinal detachment, or vitreous hemorrhage. However, do not do an ultrasound if there's any suspicion of an open globe. So let's get back to our case. So our patient had a CT orbits without contrast, and it showed significant right-sided periorbital edema, but it was otherwise unremarkable. Ophthalmology was consulted and did an EUA in the ED. The exam showed a small partial thickness right upper eyelid abrasion that was already healing on its own, and sutures were not indicated. There was a subconjunctival hemorrhage with mild chemosis, a 4 mm corneal abrasion likely contributing to the patient's eye pain. Luckily, there was no urgent ophthalmology trauma identified that needed repair, and the left eye was unremarkable. I'll list the treatment plan here. The patient was very happy to be discharged home, and she was more than ready to cuddle and hopefully not run with her new puppy. So to wrap this up, we went through the high-yield diagnoses to be aware of in a pediatric blunt eye trauma. If you want a list of it, go ahead and click the link that's in the description to get a downloadable copy. If a pediatric patient sustained a blunt trauma to the eye leading to a swollen shut eye, the clinical exam is key, which often involves consulting ophthalmology. Imaging can be used when indicated as an adjunctive tool. And in any and every eye trauma, whether it's a pediatric patient or adult patient, rule out an open globe. My personal meter, will I be able to sleep at night if I walk away now? And if not, I need to get more information.